over 1 million people will die this year from a disease that we've actually known how to cure for nearly a century.
Yeah, which is just staggering to think about.
Right. I mean, the medicine exists, it works, yet the deaths just keep happening year after year in these massive numbers. So welcome to today's deep dive.
Glad to be here.
Today we are diving into a collection of really incredible insights from a Zoom panel of public health professionals, epidemiologists. They got together to dissect John Green's book on the history of tuberculosis.
Right, the PB book.
Yeah, but let me be clear right up front for you listening. Our mission today isn't to give you some boring biology lesson on a microscopic bacteria.
Oh, far from it. I mean, if you view tuberculosis solely as a biological issue, you completely miss, well, the actual mechanism of why it still exists today.
Exactly.
The disease is really a profound lesson in what health professionals call the social determinants of health.
Which sounds technical, but it's really about society.
Well, exactly. The discussions we're looking at today, they prove in real time that diseases are shaped by poverty, by racism, by colonialism, and pharmaceutical economics, just as much as they're shaped by microbes.
Okay, let's unpack this. How is it physically possible that a 100-year-old cure is consistently, kept out of reach for the people who need it the absolute most?
Well, to understand the modern devastation of TB, you really have to understand its history, because the societal perception of this disease, it underwent this violent, just complete reversal.
Well, yeah, the history part of the panel was wild.
Right. If you go back to the 18th and 19th centuries, among affluent white Europeans, tuberculosis wasn't viewed as this horrible plague. It was actually considered glamorous.
Which is just a totally wild concept to wrap your head around today.
Big glamorous.
Lethal infection.
It sounds completely absurd now, I know.
Yeah.
But the disease caused extreme weight loss, a very pale, kind of translucent complexion, and dilated pupils. Yeah, and in that specific cultural context, those physical traits were seen as highly romantic. They were delicate and desirable. It was like fully embedded in the fashion and the literature of the elite.
And the medical treatment for the wealthy totally reflected that romanticism too. Like if you contracted it and you had the money, you didn't go to some sterile hospital ward.
Right, no, you went to a sanatorium.
Yeah, which was essentially this luxury mountain retreat disguised as healthcare. The protocol was basically resting on lounge chairs, breathing crisp alpine air, and, eating highly nutritious, rich foods just to restore your vitality.
It's an incredible demonstration of how wealth dictates the experience of illness. Like only those with massive privilege could even access those early public health measures.
They were isolated, but in absolute comfort.
Exactly. But, that empathy had a really hard limit. As medical science advanced and the demographic data became clearer, society suddenly realized that TB wasn't just this disease of tragic poets. It was ravaging Black American communities and these massive impoverished populations across Asia and Africa.
And the moment that demographic reality set in, the cultural narrative just flipped. The empathy evaporated completely.
It really did.
It went from this poetic affliction of the elite to a heavily stigmatized, dirty disease of the poor. There's this quote from the experts discussing this history that is just, it's haunting.
Oh, I know the one you mean.
Yeah, they said, the cure is where the disease is not, and the disease is where the cure is not.
That phrase just perfectly distills the geographic and economic divide that, frankly, still exists today. The moment the demographic shifted, or rather society's awareness of who was dying shifted, the funding and the prioritization fundamentally changed.
It actually makes me think of the parallel to GLP-1 drugs today, like Ozempic, which they brought up in our source material.
Oh, that's a great comparison.
Right. We have this highly complex medical reality, like metabolic disease and obesity, that is deeply tied to food deserts, poverty, systemic health disparities. But society at large only seems to obsess over it when it becomes a cosmetic weight loss trend for celebrities and the wealthy.
Exactly.
It makes you wonder, doesn't this prove that how much funding a disease gets is entirely dependent on the zip code of the people getting sick?
The history of global health absolutely supports that. Look at the trajectory of the HIV and AIDS epidemic.
Oh, yeah, true.
In the developed world, what's highly effective antiviral therapies were created, which essentially turned the virus into a manageable chronic condition for affluent populations. The global urgency took a massive hit.
Because the wealthy were safe.
Right. The immense funding streams for a universal cure slowed down dramatically, and that left populations in developing nations to just fend for themselves for years. The focus and the money, it always follows the capital.
So when the focus shifts away, The people left behind are basically stuck with the medical scraps. And that brings us to the grueling reality of how tuberculosis is actually treated on the ground today.
Which is brutal.
It really is. The regimen sounds way more like a punishment than a cure. We are talking about patients having to take up to 13 pills a day for at least 9 months.
And these are not gentle medications either.
No, not at all.
The toxicity is severe. Patients experience intense nausea, joint pain, liver toxicity, sometimes even severe neurological effects. It is a really brutal, exhausting marathon for the human body.
I can't even imagine.
And here is where the public health crisis really compounds. If a patient stops taking their medication halfway through, maybe because the side effects are just intolerable, or maybe they lose their housing, they develop multi-drug-resistant TB or MDR TB.
Wait, I need to pause here and admit some confusion because I always hear that stopping antibiotics early creates these like superbugs, but I don't actually understand the biological mechanism.
It's a bit counterintuitive. Like, how does not taking medicine create a stronger bacteria? Are the germs, I don't know, mutating in real time to fight the drug?
Well, it's not so much that they're mutating in real time to fight the drug. It's more of a brutal game of natural selection happening right inside your lungs.
Okay.
When you get infected, the billions of TB bacteria in your body, they aren't all perfectly identical. Some are naturally a little weaker, and some possess slight genetic variations that make them a bit more robust against the medication.
Okay. Yeah, I follow that.
So when you take those first few weeks of the 13 pills, the medication acts like a scythe. It easily kills off the vast majority of the bacteria, the weaker ones.
Right, and that's when you stop coughing and start feeling better.
Exactly. You feel better. But the toughest, most naturally resistant bacteria are actually still alive. If you stop taking the pills right then because you feel fine, you have just eliminated all of their competition.
Drugs will just no longer work against them at all.
That's terrifying.
It gets worse. Treating that new MDR-TB strain requires second-line drugs that are exponentially more expensive. They take much longer to work, and they have even more devastating side effects.
Like what?
Well, including permanent hearing loss, for one.
For bugs, public health officials use a strategy called DOTS, right? Which stands for Directly Observed Treatment, short course.
Yes, DOTS.
And it sounds incredibly intense. I mean, nurses actually go out into the community to physically watch patients swallow every single pill every single day.
It is a massive logistical undertaking. Just huge.
I have to push back on this approach, though. Like, we're taking marginalized people, many of whom are dealing with extreme poverty or homelessness, and forcing them to take medication under strict government observation. It feels deeply patronizing, like we're treating adults like children who can't be trusted.
What's fascinating here is the impossible tension between civil liberties and public safety. Health officials are acutely aware of how invasive this is, you know. Many patients feel immense resentment, and they feel totally policed by the process.
I mean, I would too.
Right, but public health departments are looking down the barrel of an MDR-TB outbreak, and that operates through airborne transmission, so it could literally decimate an entire city block. Because of that severe threat, health departments hold a rare level of legal authority.
Wait, how much authority?
Well, in certain jurisdictions, they possess actual police power.
Yeah.
No, there are documented legal cases where patients who repeatedly refuse treatment for highly infectious MDR-TB have actually been incarcerated in specialized medical lockdown facilities just to protect the broader public.
That is genuinely terrifying. You could literally be locked up just for not taking your medicine.
It really highlights the extreme stakes. But, you know, enforcement alone is a failing strategy.
Right, you can't just arrest your way out of a disease.
Exactly. Public health workers know that you cannot mandate someone to swallow 13 toxic pills on an empty stomach while they're sleeping on a park bench. To get compliance, health workers often have to step in and solve the social determinants first.
Meaning what exactly?
They have to secure predictable housing for the patient just so they can physically find them every morning. And they have to provide high-calorie food so the patient can physiologically tolerate the medication without violently throwing it up.
And they have to navigate the intense social landmines surrounding the disease, too. Still using an archaic, grueling system to cure a centuries-old disease. The infectious disease doctors on the panel were clearly so frustrated by this lack of innovation.
And the root of that stagnation lies firmly in the economics of the pharmaceutical industry.
Of course it does.
Pharmaceutical companies are publicly traded businesses, They're driven by quarterly profit margins, and the highest financial returns in that industry come from daily maintenance drugs.
It's stuff you have to take forever.
Exactly. Medications for blood pressure, cholesterol, diabetes, things a large population has to take indefinitely. A permanent cure, particularly a cure for a disease that primarily affects populations in developing nations with very little purchasing power.
Let me guess. It offers a terrible return on investment.
The worst.
Okay, I understand why they might not want to invent a completely new drug from scratch, but what about the drugs we already have?
Yeah.
I need you to explain this concept of patent evergreening because I honestly don't grasp the legality of it.
It's a tricky concept.
The panel called out companies like Johnson & Johnson for this. If a patent only lasts for 20 years, how do pharmaceutical companies legally maintain a monopoly on these drugs for decades, keeping all the generic competitors locked out?
It is a brilliant, albeit very controversial, manipulation of intellectual property law. It relies on something called secondary patents.
Okay.
When a company invents a new drug, they get a primary patent on the base chemical compound, and that gives them their initial 20-year monopoly.
Makes sense.
But as that primary patent nears expiration, which is the exact moment when cheap generic versions should legally be allowed to flood the market and drive the price down, the company files a secondary patent for a minor modification.
Wait, what kind of modification? Like a new ingredient?
Not even. It could be changing the delivery mechanism from a capsule to a tablet. It could be combining the drug with another existing medication into a single pill. Or even just altering the dosage schedule so you take it once a day instead of twice.
Are you serious?
Completely. They secure a new patent for this new and improved version, aggressively market it to doctors, and sometimes quietly pull the old version off the market. They effectively restart the monopoly clock.
Wow.
Yeah, ensuring generic manufacturers have no viable product to compete against, which keeps the price artificially sky high.
So it's a legal loophole that literally prices entire countries out of survival.
It is a daunting systemic failure, absolutely, but it is not unbreakable. The late Dr. Paul Farmer, whose monumental work in global health is heavily detailed in the book Mountains Beyond Mountains, he faced this exact rigged game. He was working in impoverished areas of Peru dealing with horrible outbreaks of MDR-TB. The second-line drugs required to save those patients were priced by pharmaceutical monopolies at upwards of $10,000 per patient.
$10,000 in Peru. And he couldn't exactly throw a bake sale to pay Pfizer that kind of money for hundreds of patients.
He really couldn't. Furthermore, the World Health Organization initially pushed back against him, basically arguing that treating MDR-TB in poor nations was simply too expensive and not cost-effective. They suggested focusing only on prevention.
Which is basically saying, just let the currently sick people die.
Right. But Farmer refused to accept that death sentence. He utilized deep systems thinking to completely dismantle the monopoly.
Okay, how do you dismantle a multi-billion-dollar monopoly from a clinic in Peru?
By changing the market dynamics, Farmer and his team didn't just appeal to morality. They gathered undeniable clinical data proving that community-based treatment for these patients was highly successful.
Okay.
Armed with that rigorous data, they went to international funding mechanisms and essentially created a pooled procurement system.
So they bought in bulk.
Basically, yeah. By grouping the global demand together and guaranteeing a high volume of orders, they bypassed the monopoly and coaxed generic manufacturers to enter the market and produce the drugs at cost.
That is brilliant.
Through sheer strategic leverage, they drove the price of the treatment down from $10,000 to roughly $100.
So what does this all mean? It means we can't just vaguely point to poverty as some unsolvable wall and give up.
Yeah.
It's a regulatory problem. It's a logistics problem.
Exactly.
If the free market refuses to innovate or provide affordable access on its own, it requires immense political will and strategic government intervention. Like, we need mechanisms like patent buyouts or guaranteed volume contracts to force the creation of better combination therapies that don't literally torture the patient.
Political will is the ultimate catalyst, for sure. But political will does not generate itself in a vacuum. Politicians react to the public. Which brings us to the final and perhaps most difficult hurdle.
Right.
How do you get the general public to actually care about the millions of people dying from this?
This was a huge realization among the epidemiologists panel. I mean, they are publishing these brilliant peer-reviewed papers in prestigious medical journals detailing these terrifying mortality statistics. And it is completely failing to reach the public.
Totally failing.
No one outside their academic echo chamber is actually reading them.
Because human beings fundamentally do not connect with statistics. We connect with narrative. Decision-making, even regarding highly complex global health policy, is ultimately driven by emotion, not data.
There are incredible cultural examples of this, too. Take the famous Hayao Miyazaki animated movie, My Neighbor Totoro.
Oh, such a good example.
On the surface, it's a magical film about forest spirits. But underneath, it is this deeply empathetic story about a family dealing with a mother who is isolated in a tuberculosis sanatorium.
Right, but it's subtle.
Very subtle. It doesn't beat the audience over the head with clinical public health messaging. It simply shows the human toll, the isolation of the mother, the fear and longing of the children. And by doing that, it normalizes and destigmatizes the disease in a way a government pamphlet never could.
We see that same narrative power in first-person advocacy, too. The panel highlighted a specific patient named Henry, who was featured in the Marco Polo chapter of John Green's book.
Oh yeah, Henry's story's amazing.
Henry recognized that to the medical bureaucracy, he was just another data point to be managed or, frankly, ignored. So he bypassed the bureaucracy entirely. He started a YouTube channel.
He just went straight to the public.
Exactly. He put his face on camera, amplified his own voice, and publicly documented his struggle, literally demanding the treatment he was being denied.
He forced the establishment to look at him as a human being. You just have to meet people where they are, which actually leads to an analogy from the epidemiologists that really stuck with me. They call it the football stadium analogy.
Yes, it is such a vital concept for understanding the limitations of the human brain.
So if a news anchor looks at the camera and says, the mortality rate for this disease is 10 per 100,000, we feel absolutely nothing. Our brains physically cannot process that number as a tragedy. It's just abstract math.
Right, doesn't mean anything.
But if you tell people to imagine they are standing in the middle of a packed college football stadium, 100,000 screaming fans, and then you tell them to look around the bleachers and realize that 10 specific people sitting in that crowd are going to die.
The abstraction just vanishes.
Exactly. It becomes horrifyingly real. We have to translate these massive global health statistics into the football stadium if we want to cut through the noise of modern media and actually compel people to care.
Data provides the blueprint for the cure, but empathy is the engine that actually delivers it to the patient.
So let's take a breath and look back at the incredible ground we've covered today. We started in the exclusive, romanticized sanatoriums of the past, where a deadly disease was treated like a luxury spa retreat for the wealthy.
Right.
And then we moved into the grueling modern-day reality of marginalized patients choking down 13 toxic pills a day under the watchful eye of the state just to prevent the rise of untreatable superbugs.
We unpacked the complex legal maneuvers of patent evergreening, too, that keep cures locked behind corporate monopolies. And we explored how strategic systems thinking, like that of Paul Farmer, can fundamentally dismantle those financial barriers.
And we ended on the ultimate realization that ending a global health crisis requires storytelling just as much as it requires science. You can have the cure, but, if you don't have the narrative, the cure just stays on the shelf.
If we connect this to the bigger picture, you just cannot combat global health inequities without understanding the social forces that drive them. I highly encourage you, the listener, to pay close attention to how modern health crises are framed in your own news feeds today.
That's great advice.
Notice who is centered in the narrative with empathy and whose suffering is being reduced to just another statistic.
It completely changes how you consume the news.